Welcome everybody. Hopefully it looks like everything's working anyway. So just so everybody knows, I'm just going to share my screen. We do have a couple of housekeeping points just to cover. We have set this up via a Teams webinar feature, which is a fairly new feature to us. But everybody's mic, all the audience mics will be muted just because when it's large groups like this, there can be a lot of interference. But so we won't be able to hear anyone until we unmute you. We will be doing a dedicated Q&A session, specifically at the end once we've had our speakers. So you can either pop questions in the chat as you go along, or we will have time towards the end to go through questions. I'm just going to change my settings just so I can see a little bit more. There we go. Right, excellent. So the session will be recorded, everybody, as well, just so you're aware if anybody has any issues with the recording also. So welcome. My name is Jack. I'm the project delivery lead for CVD prevention for North East North Cumbria ICB. Dr. Raj Bethapudi was unable to make it today, but we have Dr. Gareth Forbes on the call, who will be leading for the majority of the session once we come to his part, which is going to be around utilising the CDRC tools to support CVD prevention. We do have some of our CVD prevention clinical leadership team on the call as well, which I'll talk about just in a couple of intro slides, which I'm going to go through just now. But as I mentioned, feel free to pop any questions in the chat, and we will have a dedicated question and answer session towards the end. So I'm just going to talk a little bit about the North East North Cumbria CVD Prevention Network / ICB programme. I guess the rationale behind it and the work that we do. So a lot of the work is all tied into the NHS long-term plan, which I'm sure many of you will be aware of, which sets the ambition of preventing 150,000 heart attacks and strokes, dementia cases over the next 10 years. So I suppose as a North East North Cumbria region, we are supporting that work against the progression on the long-term plan. But CVD is the biggest area where we can save lives. So there's lots of work to be done on CVD, and particularly CVD prevention. So NHS England do have national priorities for CVD prevention, which I do have up on the screen here. Now, we also have some targets along the bottom, which are from the operational planning guidance from NHS England. Now, these metrics are currently 23-24, and we are awaiting the new targets from NHSC, which were meant to be released just before Christmas, but there is a bit of delay on these. So these are subject to change, these targets. However, they're most likely going to be similar, and the similar targets that we're working against. So North East North Cumbria ICB is particularly measured on these three targets at the bottom, and these are to increase percentage of patients with hypertension treated to NICE guidance, so getting their blood pressure within a healthy range to 77%, increase the percentage of patients aged between 25 and 84 years with a CVD risk score greater than 20% on to lipid-lowering therapies to 60%, and then a target around addressing health inequalities, which is always on the radar. Now, I guess the national priorities are the four along the screen here as well, which is around system leadership to support the progress on the long-term plan, which I mentioned just before. So I'll come to the slide next about our system leadership that we've got in place for this. There's a big part of targeting the unwanted variation which exists across the system. So there is plenty of practices which do brilliant on CVD prevention and tackling the ABCs in terms of the detection of hypertension, the treatment of hypertension, etc. But there is some areas, could be certain PCNs practices where performance might not be so good. So we're here to support and target that variation. As I mentioned there briefly, improving the detection and the management of the ABC conditions through support and general practice and work with system partners. So I'll talk a little bit about the work that we're doing and the support offer that we've got with our CVD prevention clinical leadership team within the ICB. and around always looking at that MEC approach as well. So how can we utilise any MEC opportunities to raise awareness of CVD prevention, potentially blood pressure checks, community settings, stuff like that. So as I mentioned, I previously had a governance slide on this, to be honest, but as many of you may know, the ICB is currently going through change, so that governance slide might not be as up to date, and we'll have a no more of an updated slide regarding that in the future. But in terms of system leadership, Dr. Neil O'Brien, Medical Director for the ICB, and Dr. Alexandra Kent are senior responsible officers for this programme, so is supported as a priority for tackling CVD prevention. We have Wendy Burke, Director of Public Health in North Tyneside, and Dr. Raj Bethapudi, who I mentioned earlier, as the co-chairs of the network and the programme. And then I guess the programme is supported by Elaine Fairbairn, who's a Clinical Network Delivery Manager in NHSE, and me, the Project Delivery Lead within North East North Cumbria ICB for CVD prevention. This is a brief overview of, I say brief, there's lots of text here. You don't need to read through it all now, because I know that it'll be hard to read. The slides we will share after, but this is our plan, which was built last year for the 23-24. It's still in place, obviously, and it ultimately details some of the work which we've been leading on, and it all ties in. You've got the left-hand side, you've got the national deliverables, which are those deliverables which I went through on the previous slide from NHS England, and how we tie in with the work that we're doing with North East and North Cumbria. So for example, system leadership, we have our CVD prevention clinical leadership team. We run various educational events and sessions like here today. We have Dr. Neil O'Brien and Dr. Alexandra Kent, as I said, for SROs for the programme. Various bits of work around supporting general practice, which I'll come to. That target and unwanted variation using the data sources that we have available to look at where we should target our efforts. And a couple of bits on MEC and looking at how we work better with system partners, different sectors across the system, etc. But you can have a little look through that once I share the slides. There's a lot of text going on there. Now, I think we have Catherine and Georgie. I'm not sure about Andy. I didn't see his name on the call, who are part of our CVD prevention clinical leadership team, which are doing some, I think Andy just raised his hand there as well, who are doing some supportive work with GP practices and PCNs across the region. So we look at the data, particularly from CVD Prevent, to identify where there might be variation, particularly practices and PCNs which might not be performing as well on things such as treatment to target for hypertension. It could be on getting people on lipid lowering therapy for who's got a Q risk of 20 or 10%, etc. And how we look at those that might not be performing so well and looking at how we might be able to support these. And it's usually in a form of an educational session with these practices or PCNs. So Georgina, Catherine and Andy have been out to various practices, whether this has been virtually or face-to-face, looked at what the barriers are, worked with the practice as a tailored plan to look at how they might be able to improve the numbers. So the work that we're doing is a very supportive approach. It's not here to tell anybody off. It's here as a free supportive offer to help improve CVD prevention numbers and ultimately improve the detection and management of those ABC conditions. So we're looking at atrial fibrillation, hypertension and lipids. So lots of different ways we can look, but it is tailored to the practice to understand what their barriers are and how we can help. Obviously, this is targeted at those that might not be performing so well, so it is trying to address that variation. But if there is people interested in the work that we're doing, we can always have a conversation, but ultimately it's targeted those that might need it the most. So we are looking at those which don't perform so well on the CVD prevention indicators. Other bits of work from the CVD prevention programme and network that we have ongoing is we're currently in early conversations around looking at some insight work. So particularly looking into deprived communities to understand what is their knowledge of CVD, to know what CVD means, to know how they can get checked for the ABC conditions, they're aware of the risk associated with CVD, how it can cause heart attack and stroke, etc., to potentially inform some future work, because there's a lot of I say communication strategies out there, a lot of public facing comms already out there, but it's better to understand what is the community's current understanding of CVD and where should we target, what can we do to help? Is it around health literacy stuff? Is it around general knowledge of where can get checked signposting? So hopefully that insight work will inform us with some future targeted work. Obviously, we have our meetings, so CVD Prevention Network meetings, which some of you may be part of the distribution list. I will share my contact details at the end if you do want to become part of the network distribution list, where we usually host a quarterly meeting to update on the work that we're doing. We have a few educational speakers as well on various topics relevant to CVD prevention. We have various webinars like this, and we've done a face-to-face event, which was in September last year. So if you're part of the network distribution list, you'll be kept up to date with that stuff. So you can email me with your job role and I can get you added to that. We have been successful in obtaining some funding from NHS England to deliver a project to tackle health inequalities. Now, this project is going to be around basically putting blood pressure kiosks in community centres, could be Bangladeshi centres, it could be job centres, etc. Usually where we've got footfall of deprived communities, ethnic minority communities, and we're going to support engagement through health champions to support use of the blood pressure kiosk. They will also be provided with awareness information, potentially a home blood pressure monitor if it flags people with elevated blood pressure after various readings. They'll be provided with a home blood pressure monitor. So I suppose the aim of it is to go to the communities which typically don't engage because they're not coming to the GP practice. How do we go to them and support hypertension case finding and management? Of the lipids network, which is a separate thing, so the CVD prevention network does tie in with the lipids network activity that's going on, and there is a project early days with Health Innovation, previously HSN and OHID around developing CVD specific community champions. So you have your standard community champions, which are volunteers which spread health messages, promote health messages in community settings, but specifically developing CVD community champions to raise awareness of CVD knowledge, awareness, etc. Right. Risks and challenges of the North East North Cumbria CVD Prevention Network programme. I suppose the scale of the challenge with CVD is it's a massive, one of the leading causes of death. But we have a small amount of funding short term as well, so that is a challenge. The variation which exists across PCNs and practices, which we're attempting to tackle. Obviously, the workforce capacity that we're all aware of in primary care, data timeliness and quality, which I'll come to shortly, around CVD prevent and the uncertainty and future support of the role of clinical networks. So the ICB is going through change, as is NHSE as well. It's important to highlight any risks and challenges that we have. Now, I'm going to hand over to Gareth very shortly. I just want to do a quick mention of CVD prevent. I don't want to take away from what Gareth is going to go through, but CVD prevent is I suppose a national tool which is available to anybody. Anybody can go on the CVD Prevent website and look at CVD prevention data from national level, ICB, PCN, down to individual practice level. It's really useful to see how you're doing against numbers, but to be honest, you might have more live and up-to-date data in your GP practice systems, no doubt, compared to CVD Prevent, because the issue is with CVD Prevent that the data is slightly outdated. They've just released data about a week and a half ago, and it is from GP systems, extracted from GP systems September 2023. So it is a bit behind, but it is good from what we have access to have a picture of looking at how people are doing. This is just an example of how it looks on the website. I won't go through it today because I do want to hand over to Gareth in a sec, but it is just, you can look at over time, you can look at between ICBs, you can look between PCNs, you can look at the practices within a PCN and compare how you're doing against your neighbours, etc. Fairly easy to use once you've had a little play around with it. If anybody wants any further information, there is videos on the website. There's a bit of a demo video. If you want a bit more of a wider demo, say for some of your teams within primary care, I will be happy to set something up and I can show you through when we have more time. But just raising the awareness and the profile of CVD prevent, that it is a useful tool to utilise to see how you're doing some of the CVD prevention indicators. Right, so that is my email. I will pop that up at the end as well if anybody's interested in joining the CVD Prevention Network distribution this way. You'll be kept up to date with the stuff that we have going along. But I'm going to hand over to Dr. Gareth Forbes now, who will going to do an overview of CDRC and how we can use the digital tools to support your work around CVD prevention in your practice. So I'll stop sharing and hand over to you, Gareth.
Have you got the presentation?
Yeah, see that, Gareth.
Great. Okay, so I'm going to run through some things that might help people. I'll talk briefly first about the approach that we take, just in case people haven't heard this before. But basically, we try and keep things as simple as possible. We think of interventions as 3 different interventions. You've got screening, you've got case finding, which is taking information that's already in the record that hasn't been kind of actioned properly, and then there's condition management. So in the CVD prevention space, that might be screening, might be finding people who need an NHS health check. Case finding might be finding people who've had a raised HbA1c but haven't been coded with non-diabetic hypoglycemia, and condition management might be making sure that people with diagnosed hypertension are controlled to the right level. And then we've got what we see as 4 opportunities to intervene with people. You've got opportunistic approaches where somebody comes to see you with a cough and you realise that their blood pressure is not controlled. You've got regular reviews of people coming along for the long-term condition reviews. You've got a systematic search where maybe a pharmacist is looking at all the patients across the population and seeing who might be eligible for a particular lipid-lowering therapy. And then you've got things that change in the record that might prompt you to want to do something. So, for example, someone with AF is diagnosed with hypertension, which pushes their CHA2DS2-VASc score up to a level where they need anticoagulation, and we would want to prompt the user to say, have a think about anticoagulation. So what I'm going to concentrate on today, given where we are in the cough year and the discussion about population change and trying to reduce inequalities, is firstly a bit about case finding, because the more you can do for case finding at the moment will help you with your cough indicators and your cough payments for the end of the year. So there's a whole series of case finding tools within the CDRC resources, including searches, prompts, which will show icons on the patient's record when they're loaded. They're all opt-in, so all of our resources are opt-in. We won't turn anything on unless you ask it to be on, and templates. And just to give you an idea of the impact of that, so my surgery has got about 6,000 people, and we've just done in Derwentide, we've been running a quality and safety improvement scheme called Quasi for the last 6 or 7 years, and part of that is case finding for all the practices in Derwentide. And we've been trying to increase our detection of these conditions that are related to cardiovascular disease. So this is the increase in prevalence in my practice over that time, and this is absolutely increased. So 6.7% of the whole population, an additional 6.7% of the population are now diagnosed with hypertension compared with when we started. So you can see we've seen lots of extra patients being diagnosed with AF, CKD, diabetes, hypertension, non-diabetic hypoglycemia, and obesity. And this is all starting from a high baseline. My practice had a high prevalence even before we started, and you can see kind of satisfyingly that the prevalence of cardiovascular disease is either going down or staying flat. So that's what we'd hope to see. We'd hope to see an increase in the detection of the risk factors and the risk conditions, and then as we get those managed, hopefully to start seeing a reduction in the prevalence of cardiovascular disease. And just in terms of the finances, so my practice for these cough conditions currently receives an extra £13,500 each year, compared with it if we had the average England prevalence. And of that £13,500, about £4,500 is due to the extra cases that we found in the last few years. So it does make a significant difference to your practice finances. There are also additional benefits, And if you find more people with NDH, you can refer more people for NDPP, and you get paid for those referrals. So there are additional benefits as well as just the prevalence. So what I want to come on now, the main part of what I want to talk about is kind of thinking about CVD prevention based on the interventions that we can deliver. So we're all delivering CVD prevention based on long-term condition reviews, and that's important, and we should do it. You know, getting people in for their annual reviews and then titrating their treatment if necessary. But we know that lots of people are slipping through the net of that process. So we need these additional processes again. So the opportunistic intervention or the systematic intervention. And this is tricky because CVD prevention is becoming increasingly complex. Multimorbidity is now completely the norm. Hardly any of our patients have just got one risk factor or one condition. We're completely overwhelmed and under pressure. We need to make this as effective and efficient as possible, and we need to make the best use of the staff and the skill mix that we've got. So if you think just about, I've just tried to, you know, I'm not expecting you to read all this, but just thinking of some of the things that we're being asked to do, you know, all the different things we're being asked to monitor, the things we're being asked to screen for, the referrals we're being asked to do, the different medications and the safety implications of those medications. And often those medications are indicated for multiple conditions. So SGLT2 inhibitors now, we're supposed to be using them for some people with diabetes, some people with chronic kidney disease, some people with raised cardiovascular risk, some people with heart failure. So it's quite difficult to keep all of this in your head. This is the CVD integrated prevention dashboard that we've built to try and help practices and individuals work their way through this morass of information. So the first part of the dashboard is kind of telling you how you're doing as a practice. This is my practice. So we've got the ABC conditions and CKD on the end here. So it kind of tells you your prevalence. It tells you how you're doing for monitoring. So the second line here is monitoring. The next line is management. So for example, for the AF, I've got 98% of my high or moderate people anticoagulated or got recorded with a good reason why not. Here's blood pressure. So all the people with high blood pressure, I've got 78.2% of them with those QOF style targets, slightly better if you look at the NICE target, because NICE and QOF are slightly different. And then this fourth line is kind of a case finding type element. So 3.8% of my population have got a high blood pressure but are not on my hypertension register. So these are the people I need to be targeting for a recheck of their blood pressure or home blood pressure monitoring. Similarly, for the lipids, 3.3% of my population have got an estimated Q risk of more than 10 and haven't been assessed yet. So these are the people we need to target for NHS health checks or just an ad hoc CVD risk assessment. And a very small number of people who've got a low EGFR who we ought to be checking to see if they've got CKD. So there's a kind of basic view of how you're doing as a practice. And there are dashboards which give you more detail for those three ABC conditions. So you've got one for AF, one for blood pressure, one for lipids, and then the integrated one, which I'm talking about now. The next thing to layer onto this is the issue of dealing with inequalities. So the core 20+10 is quite a blunt instrument. If you practice in a relatively deprived area, then the vast majority of your practice will be in that group. So it's not very discriminatory. So what we've done is created a different tool, if you like, to try and identify the people who are at risk of needing more help or needing a different approach to deliver their healthcare. So we've taken all these factors that you can detect from the medical record, and we've put them all together and sort of drawn a line, a threshold line, so that we can create tiers of risk, if you like, of people who are at high risk of inequalities and really high risk of inequalities. Then we combine, so we then combining all the interventions that the patient might need, combined with their risk of needing additional help, and being really careful when we build the searches that we get the sensitivity and the specificity right, because we're so short of time that we need to make sure we're targeting the right people. So there's very careful checks put in place to make sure that people who don't need intervention or have already had an attempt at intervention can be excluded for a period of time. So, for example, if your blood pressure is poorly controlled and you speak to the person and they say, well, I don't want to control it anymore, you can record that and they'll drop off your list for the next year, so that you can really target your intervention. Similarly, simple things like it doesn't look at the last blood pressure if the last blood pressure was in the last 4 weeks, because what we would hope is that if you record someone's blood pressure and it's high, then you do something about it. So you don't want to be going back to that person until you would plan to recheck their blood pressure after the intervention has bedded in. Same thing for lipids. So we're not going to count lipids that have been taken in the last 8 to 12 weeks, because hopefully you've done something about it, and that change will then feed through to the next blood check. We're also very keen to have patient-specific care. So right throughout the system, you can set patient-specific targets. So you can set a target blood pressure, you can set a target lipids, and you can, if that target overrides the NICE target, then it will take them out of the, this patient needs intervention list. And then finally, we're thinking about maximizing the use of the different people we've now got in the clinical team. So putting all that together, at the second half of the dashboard that I showed you to start with is the kind of the meat of it. These are the people that you might need to intervene with. So it starts with this top part here, which splits the people down into people who might have issues that are related to engagement, people who might have issues that are related to optimization, and then just combining the two. So engagement is things like coming for their long-term condition reviews, having a blood pressure check, having the cholesterol tested in, dropping in their ACR. So people in the engagement list could be tackled by a care coordinator or by an admin person, because you don't need a clinical experience to phone someone up and say, text somebody and say, would you like to come for your long-term condition review, or please would you drop in your ACR, please. The optimization things are going to need a clinician, so that might be a nurse practitioner, it might be a pharmacist, it might be a GP, but it's things like, does this patient need medication starting or stopping? Do they need medication intensifying? And then the third option is just if you want to do it all together, it allows you to do that. So the box underneath is the first one, drop down, and you can see how we're counting. All this is doing is counting the number of interventions the patient needs, so that you can prioritize your work, because the numbers are so vast that if you tried to do everybody, you would just give up straight away. So we can see 2 columns ranked by the number of interventions and split into everybody and then people who might need more help. So this group over here, you might want to take a slightly different approach. You might really want to set a care coordinator working hard on trying to approach this group of people. And you just click on the jigsaw pieces and that will give you the number. The default when you open this is that it will exclude people who've where you've tried. So if you've spoke to someone and said, can I lower your blood pressure, and they say no, then it will exclude them. But you can drop this box down and it will then include everybody. So you just get everybody who's eligible for an intervention, but much less specific, because you'll end up with lots of people who've already been approached. So tied into that, what you need next is to be able to see what's going on, because all of these problems are so complex. And that's where the cardiovascular disease risk prevention view comes in. So what this does is it shows you everything you should need to know about the patient and cardiovascular disease risk prevention, and hopefully all color coded. So at the top, you can see the risk factors and conditions. So this person's got NDH. It looks like they're at high risk of CVD. They've got a Q risk that was done 3 or 4 years ago, which was 10, so it'll be higher than that now, and they've got hypertension. Then this next section is the kind of key measurable stuff. So we can see they're an ex-smoker, last checked in 2021, and they get a bit of exercise. We can see that their blood pressure is above target, it's in red, and it's overdue. So this person hasn't had a blood pressure check for a good 2.5, 3 years. Haven't had a BMI checking for the same length of time, and significantly overweight. Can see that they've got NDH, and again, not really overdue a check. Kidney function's okay, but massively overdue. And ACR was okay last time it's checked, but kind of completely overdue. So that's something that an admin can easily see, or a healthcare assistant, and could easily say, right, you need to come in for these checks, we'll get you in, or we'll just do them. Then the next section down here is the interventions that you might think about delivering. So for this person, it might be advice about weight management or a weight referral. This person, we need to be thinking about start offering them a lipid lowering. It's telling us that their blood pressure is not achieved, and it's telling us that we might want to think about setting a blood pressure target. And alongside each intervention, there's a button that takes you off to the place where you can deliver that care. This is another example of somebody else. So this is a person with fairly mild CKD, type 2 diabetes, incredibly high cardiovascular risk, and hypertension. So we can see this person, their blood pressure and cholesterol and BMI all seems okay, but actually haven't been checked for quite a long time, so we don't really know if that's right. And we can see that their blood sugar was pretty poorly controlled, and that's ages ago. They really haven't been along for their check, and it's telling us this person we ought to be thinking about. It's telling us to think about intensifying their lipid lowering. And that's because this person's on relatively low potency statin. It's telling us we might need to be thinking about an SGLT2 inhibitor because they've got high cardiovascular risk with type 2 diabetes, and it looks like they need a prompt review of their glycemic control. Here's someone who's really terrible. So this is somebody with diabetes, CKD1, type 2 diabetes with a microalbuminuria, incredibly high cardiovascular risk and hypertension, is a smoker, not doing any much exercise, out of date with things like cholesterol, not had a HbA1c done for ages and ages. We need to talk to him about smoking, weight. He's not taking his lipid lowering treatment. He's not taking his calcium channel blockers. He's not taking his ACE inhibitor, and so on. So you can kind of see the approach. And then this is an example of how things link through. So this is a link, if you're linking through to this person's cholesterol, lipid management. So it gives you much more information about recent lipid readings, and tells you that he's currently on atorvastatin, what his current renal function is, lets you send information leaflets to them and start different tablets and so on. And has got built-in pathways, so you can see this person's primary prevention, curious 2 to 3 more than 10%, so tells us what the pathway is for this person, and has got built-in things like statin intolerance pathway, so you can hopefully find that as easily as possible without having to hunt it down. So hopefully that kind of gives you an idea of the resources are available, and an approach maybe to improving cardiovascular disease at scale, but thinking about reducing those inequalities and targeting the people who are highest. It's not highest risk. The people who will benefit from most interventions, because you might have somebody who's very elderly and who's got diabetes and heart disease, but they're on all the right treatment. So there's no point targeting those people. You want to target the people who would benefit from interventions. So I hope that makes some sense, and I'm happy to take questions from there.
Excellent, thanks for that, Gareth. Really informative. See what you can do to find and treat the people that you need to. Tina's asked a question in the chat here, just asking how they, I suppose, access the tools.
So they're all on, if you're on SystmOne, you'll have access to them. You might have to, if you haven't already enabled visualizations, which is how these things are built, you just need to email TPP to ask them to turn it on for your practice. It doesn't do anything apart from let you access the visualizations. And then Ben, who's our admin person at CDRC, will put together just a quick guide on how to turn them on and get access to them.
Brilliant, thanks, Gareth. Any more questions, feel free to pop them in the chat. If you want to raise your hand, I will be able to unmute you as well so that you can speak. Right, I think we've got one that's come through. Right, I'll just unmute you here, Dilys, just a sec.
Hey, Dilys.
Right, if you unmute yours, Dilys, you should be able to speak now.
I'm still, oh, there we are.
There you go.
So Gareth knows that we were thinking of looking at the QOF CVD parameters across Durham. So just as a kind of, I mean, it's great to look at it in the practice because that's where all the work's done, isn't it? But I think sometimes it's also helpful to see how other practices in your area are doing, maybe outside the PCN. And I just wondered if there's any way we can share. We can have a look at that moving forward. We've asked Billy Moyle and she wants a fee for that. So I don't know whether Gareth, the cities in Durham have agreed to it.
Yeah, so yeah, I want to do that so that we can report on our own information, and we just need to sort out the information governance to make sure the practices are all happy for us to do that. We've got the technical capacity to do it. I just need to pull together some data sharing agreements and a kind of memorandum of understanding about how we do it. It's slightly just one comment on those metrics that we're asked to report to. The one about Q risk more than 20% is really annoying because it doesn't actually reward practices for what they've done. Because if you think about it, if you're doing CVD prevention properly, then you should find people way before their risk is 20%, because you should be doing an NHS health check when they're, in their early 40s or 50s, when you're hoping to get them when their risk is 12-15%. Of course, you never recalculate their risk because they all go on to be 20%. But once you've put them on a statin, you wouldn't then re-record their risk as being more than 20%, because it doesn't make any sense to re-Q risk somebody when they're on a statin, because you'll get the wrong reading. So what they're measuring actually penalizes areas that do things properly. And if you look at the CVD Prevent data, if you look at their 10% is in there as well, and North East and North Cumbria is top of the shop for 10%, whereas we're not as good for 20%.
Yeah, for looking at between the PCN you mentioned as well, you can look at that on CVD Prevent if you just type in the PCN. But as I mentioned earlier, the data is not as up to date. It's from September 2023 at the moment. So within your systems, obviously you'll have that more live data. But if you do want an overview of how each practice and do the PCN, it is accessible via that way.
The other problem with CVD Prevent is there's no exceptions in there. So it only gives you the raw data of, the number of patients with hypertension who are controlled. It doesn't allow for any exceptions of, terminally ill patients or patients who don't want to have treatment, which we could get locally.
Just a question in the chat here, Gareth. So when practice is contacting TTP, are we just asking them to enable CDRC visualization, or is there a specific terminology we need to use to ensure TTP know what we're after?
Yeah, no, it's not a CDRC thing. It's a national. It's TPP built this visualization function, and I don't know why they haven't just turned it on for everyone, because it doesn't do anything. It doesn't, it's not like one of those automatic pop-ups or something. But for some reason you have to ask them, and it's their email, which is something like setup@TPP or something like that. And you just have to say, please, can you enable visualizations at my practice, and give them your A code.
Jenny's asked about Colest 002.
My favorite, least favorite, most stupid QOF indicator ever invented. Yeah, happy to chat about call 002. What do you want to know?
Do you want me to, I'll take you off mute, Jenny? I'll just if you raise your hand, it'll be easier for me to find you on the list, because there's quite a few people in the call. There we are.
I mean, the good thing is that hopefully call 002 will disappear, because it no longer aligns with NICE. So NICE have just changed the lipid guidance for secondary prevention, so that people now have an absolute target of non-HDL cholesterol less than or equal to 2.6, or LDL cholesterol less than or equal to 2.0, which is very different to call 002, which is less than 2.5, non-HDL less than 2.5, and basically LDL doesn't count in QOF, because LDL only counts if there's no non-HDLs, and as far as I know, all our labs report non-HDL cholesterol.
You should be able to speak now as well, Jenny, if you take your mic off mute as well.
Do you want to just type it in the
Yeah,
chat?
sure, the mic doesn't work.
Many patients lipids done and coded in the last 12 months. No, I don't know. I don't know what that is. I haven't noticed that problem. If they've, I mean, generally, if they've got a non-HDL cholesterol less than 2.5, it'll be picked up, but it's got to be less than 2.5. Because call 002 isn't a monitoring one; it's a management one.
Any more questions? Feel free, pop in the chat, raise your hand, can take you off mute. Have one from Jenny.
So I mean, the issue about that indicator is it's just utterly bonkers, because you can't. There are no exceptions at all. There's no possibility of accepting patients. If somebody's terminally ill, you can't accept them. If somebody doesn't want to have any intervention, you can't accept them. If somebody literally has just had a heart attack, well, there's absolutely no point checking their cholesterol until they've been on a statin for 8 weeks, but you still can't accept them. So there are no exceptions. You can only achieve it by actually recording that cholesterol. So it's the one QOF indicator where if you were achieving 100%, you would be doing a terrible job, because you would be delivering poor care to many people, or doing things against their wishes. So if a patient had lipids recently, but non-HDL more than 2.5, more than or equal to, because it's got to be less than 2.5. I think what you're getting confused about is the SystmOne little alert says needs cholesterol test or cholesterol test due or something. It doesn't mean that. It means cholesterol test not controlled. Does that make sense, Aparna?
Any more? Now's your time.
Yeah, that's right. You can't do any exception reporting. But hopefully it'll Yeah, it doesn't matter if they declined. There's absolutely no exception reporting. There is for call 001, which is giving statins to people who have got cardiovascular disease or CKD, but not for 002, which is getting their cholesterol down. I think somebody got their hand up, Jack.
I think that was Jenny's before, just when she was going to use a mic, but I don't think it was working. You can take that down. There we go. Any more for Gareth? CDRC related? Anything about the CVD Prevention Network, ICB program? You can ask me about the work that we're doing. Just checking for any more in the chat, any more questions coming through. I will pop up just the contact details as well.
I was just going to say on the lipids visualization, there's a section for QOF, which tells you exactly how you can and can't exception report people, and gives you some guidance on which people might be accepted in which ways. Yeah, the new nice target is an either-or target. So it's non-HDL cholesterol less than or equal to 2.6, or or LDL cholesterol less than or equal to 2. Just see if I can pull that up for you in a minute.
Whilst Gareth's doing that, we've got the contact details just on the slide here, which hopefully is still up to date. I know the HSN has changed to Health Innovation now, but hopefully that email is still relevant. We've got CDRC at the top, then CVD Prevent link if you're interested in looking at CVD Prevent. There is an email for CVD Prevent if you've got any queries to them as well regarding the data or any questions. Then my email also if you've got any questions around the network, the support work that we're doing with Catherine, Georgina and Andy with practices.
So I'm just going to try and share.
All right, I'll stop mine, Gareth, just so you can share.
So this is the lipid visualization, and so here's the section on QOF. So you've got call 001 tells you how you're doing, and then it'll give you the patients who are not yet achieved, and then it splits them down into the ones that might be achievable in different ways. So for example, I've got one patient here who's on lower lipid lowering therapy, which isn't a statin. So I should be able to achieve that person by recording a statin exception, like statin not tolerated or declined. And I haven't got anyone else in these other categories that would let me accept them. So that leaves me with 14 other people to work on. Here's your cholesterol 002. So to help you work through this one, there are 3 categories of people that might help you achieve 002. So you've got the people who are not taking their lipid lowering therapy. So all you might need to do for them is to contact them, ask them to start taking their treatment, and then check their cholesterol. It's probably a bit late for that now in the QOF year, but might be worthwhile. Then you've got people who've not had their cholesterol checked in the last year. So they're the people where actually checking their cholesterol might get you there. And then this lot, the 163, are the people who've had their lipids checked in the last year but haven't achieved the targets that have been set. So they're the ones that are more difficult to achieve. And then there's just 2 other lipid related indicators for QOF. So there's 2 in diabetes about getting people on statins.
Great, thanks, Gareth. Any more questions? Any more coming through the chat? Pop your hand up if you want to speak as well. We can unmute you. One from Philippa.
Yeah, it's turned on for the unit. So you only need to do it once for the practice. What do you mean, Philippa, in terms of?
Can unmute you, Philippa, if you want to speak as well. If you just raise your hands. We go. Right, as long as your mic's on mute, Philippa, you should be able to speak now.
Thank
There we
you.
go.
Cheers. So yeah, it was just normally if we ever change anything system-wide, there's normally a little bit of pushback from people who aren't happy with the visualizations. Has everybody generally been happy with how it looks and how to navigate it, or have you had to do some training around that?
No, we haven't. Hopefully, when we try and make it as user-friendly as possible, I haven't had any big pushback on it. I mean, a lot of it is something that, you know, the dashboards in particular might be something that somebody like a pharmacist or somebody like that might use rather than everybody in the practice. And it's all voluntary, so you don't have, you know, it's not like you're saying you have to use this. You can still use your old stuff if you want to.
Thank you.
Any more for any more? Feel free, raise your hand, pop in the chat. Right, if that's all, question. Oh, I think one more. Catherine, come on, let me on. Oh, Catherine, you can speak anyway. Go ahead. You should be able to.
Thanks. Hi, Gareth. So the visualization dashboard looks great, and I can see it's very focused towards this year's QOF targets. Come April, when the QOF changes, is there something within the visualization dashboard to then focus on next year's QOF targets? How does that work?
So I mean, the QOF, all the QOF related bits will be updated with if QOF gets changed. But I mean, most of what we talked about today it's kind of not really QOF, or is additional to QOF. We're trying to concentrate on all the cardiovascular disease prevention interventions. You know, so a lot of the things that are built into that system are not counted in QOF.
Great, thank you.
Thanks, Catherine. Any more before we bring the session to a close? Great. Well, unless there are no more questions, we can bring the session to a close and give you a few minutes back of your time. But I just want to thank everybody for coming along. It's been a good turnout. Thank you to Dr. Gareth Forbes for leading on the CDR-C talk that we've had today. Lots of good informative information that can support you in finding and treating people that you need to with these tools. As I say, any further questions, the contact details that are popped on the presentation, you can take from there. And other than that, thank you for taking the time out, and thank you for your work on CVD prevention as well.